Okay, I think we start that seminar, and welcome to the LAMP seminar. And as pandemic still on, so we combine Zoom and with in-person, and this is a Zoom seminar. So it's my great pleasure to introduce today's seminar speaker, Professor Quing Zhu. And Quing got his Ph.D. In 1992 from University of Pennsylvania. And then she took a faculty position at the University of Connecticut. And in 2016, he moved to Washington University in St. Louis. And currently he is the Edwin H. Modality Indoor Chair Professor of Biomedical Engineering. And Dr. Zhu has a really wide span of research interesting, ranging from photoacoustic tomography, diffuse imaging, optical hand tomography. And in the past few years, I think he focused more on translation research, try to look at some of the hard problem in cancer detection and other disease. And Professor Zhu is also a fellow of OSA, a fellow of SPIE, and a fellow of AIMBE. And today, his presentation title is Dual Modality Ultrasound and Optic Imaging Technique for Diagnosis and Treatment Assessment of Breast, Ovarian, and Colorectal Cancer. And please join me in welcome Professor Zhu.
Thank you very much, Jingting, for inviting me. And thank you everyone for participating in the seminar. And it's really my pleasure to give a talk here. So I will start with the ovarian and the colorectal cancer using photoacoustic technology. And then at the very end, I will also talk about using diffuse light for breast cancer imaging. So the talk mainly kind of oriented toward the disease and also our solutions. How did I get started on the ovarian cancer? So you all know that this ovarian cancer is really deadly disease, and no early detection methods and tools. And the patient, when they diagnose it at the early stage, stage 1, stage 2, the survival is a lot better than the patient getting diagnosed with stage 3 and 4. But however, because of no early tools for detecting early ovarian cancers, most often when the patient shows some symptoms, they are already kind of a big cancer. You can see from the very left corner that the late stage cancers is kind of big and then metastasize to the entire pelvis and the abdomen. And then patient, the survival is very low, 5-year survival is very low. But however, if we can detect the early stage ovarian cancers, you can see the middle lower picture, and the surgeons, when even they open up, they take a look, and it's still very difficult to tell from some benign lesions because the surface doesn't have this ugly appearance compared with the late stage ovarian cancers. But you can also see that normal ovaries are kind of very shiny and collagen rich. And then another big problem is this benign masses. Like 80% of the patients who have symptoms and then show up and then got had the surgery and then got their ovaries and the mass cut out, 80% to 90% of those women will have benign lesions and they grow over years and it's kind of big. But it's very difficult to diagnose compared with the cancers. So I'll show you some data later on. So this was the current limitations. The ultrasound, the transvaginal ultrasound is used, but it's not very valuable. And this is not recommended for screening because the screening, the yield is very low and the benefit is not there. And there is a blood marker called the serial, the marker CA-125 is not very specific, and the inflammation and the endometriosis can give a higher false positive high value of CA-125. CT is not good for small lesion, and MRI is also low sensitivity, also costly, and the PET imaging is low resolution. So the real limitation is there. And how do they do in current standard of practice? They're basically pursuing surgery. So if any suspicious lesions either see by CT or ultrasound or the other palpation, and then they will basically pursue surgeries to cut the ovaries and the lesions out, and certainly costly. And also for the certain group of patients who have a higher risk for breast cancer, ovarian cancer, and then they do preventive surgery to just cut the ovaries out, and then sometimes get the breast out, but all cut out. So this is a kind of problem that can cause early menopause, impact the quality of life of patients, and also increase the risk of other cardiovascular disease. So it's really no good solution right now. So our goal is trying to see if any tool can do better for early detection of ovarian cancer. And in our optical field, the groups working on OCT and also working on other microscopy techniques and trying to do the ovarian screening, but those are limited to surgery, doing the surgery tools. So we're trying to see if we can do non-invasively. So we started with the photoacoustic imaging first, because photoacoustic imaging, as we know, that laser illumination can generate a small heat, and then heat change can cause the vibration and generates sound. If we put ultrasound transducer next to the lesion, we can detect the ultrasound signals based on the hemoglobin or tumor vascular contrast. And the basic the hypothesis is that tumors in general will have a higher hemoglobin and a higher photoacoustic signal, and then we can detect non-invasively. So we try to combine with transvaginal ultrasound transducer, because it's very natural that same transducer, ultrasound transducer, can be used for both ultrasound and the photoacoustic imaging. We just need to add light to illuminate the lesion. And then also there's advantages to illuminate using the transvaginal probe, because the vagina muscle wall typically is only like 8 millimeter in thickness. It's a very standard. It doesn't change with the patient either is fat or skinny. And we don't have that major issue as compared with abdominal approach. So we started this approach. We certainly had quite a technology development in terms of coupling light, in terms of detection, also in terms of algorithms of processing the data, and the combined ultrasound with the photoacoustic imaging. So we were actually very lucky when we had the first patient. This was back to at the time when I lived in Connecticut around 2016. We started a patient study, and the first patient we just showed that there is a red spot is a photoacoustic signal, is a hemoglobin contrast, and superimposed with the ultrasound. The first patient, we find that there's a hot spot, and then surgery indicated that this patient had an incidental finding of T1 cancer, which is very small. You can see here. And we're very encouraged. So we continued this. So after I got to WashU, and then we have a large group of GYN surgeons and radiologists that are very interested in working with us. Okay, so there's two hypotheses. One is that we might be able to detect early cancer, and the other hypothesis is that we might do better in terms of differentiation between large benign lesions versus malignant lesions, so we can reduce unnecessary surgeries and save the cost for healthcare, and also improve patient quality of life. So this is our current version of the system. We went through about 3 prototypes, and then this was our current prototype. We have this system we purchased from company. Initially, we built our system, find out the quality was not very good in terms of ultrasound performance. And then this is a system we purchased from South Korea. And then this is a probe, and this is a laser system, everything like packed into a compact box. And the student worked on the system, and the use is reasonably convenient. We just put the laser beams to the probe and lock it, and then use the before patient for the first transvaginal ultrasound, and second we do the second procedure. And there's 5 minutes to 10 minutes, we basically finish the scan and the data processing. So this is the current system. And we also had the first pilot study in around like 2017, 2018. And this example, you can see that on the left, the top is the B-scan ultrasound. This one is a larger cancer, and it's not very clear because the tumor boundaries is not very clear in this this is a later stage cancer. And then we see photoacoustic signal show the higher hemoglobin contrast. And this patient had another left ovary, and it turned out to be normal. And then we can see a very little signal, photoacoustic signal. And then we also, because we have a full optical wavelength, so we can also compute the oxygen saturation. And we see in general, the oxygen saturation value is lower for the cancer and higher for the normal ovaries and normal lesions. And this is a typical what we see. Malignant lesions see a very high concentration and also localized, depends on the size, and the lower oxygen saturation compared with the benign lesions, and higher oxygen saturation and lower signal level. So this is in principle what we find from our pilot data. So we continued from 2020, we got the second round of NIH funding, and then we're targeting a larger group of patients to validate our initial data. And this is a very exciting data we got just in a recent trial. And this patient had a fallopian tube here. You can see it was kind of enlarged based on ultrasound, and this is the ovary. And we see extensive signal. If you see the left bottom, we see extensive signal, which corresponds to higher hemoglobin concentration, and not much in the ovary region. And this patient here, this is the ultrasound. You can see fallopian tube, ovary, and this is the oxygen saturation. The D panel is the oxygen saturation is moderate to in the level. And this one turned out to be that the tube is cancer, and the ovary is normal. So it's very exciting that we actually can detect earlier stage cancers because the size is small. And typically when the size is small and the diagnosis is not very good, not based on the CT, and then based on ultrasound is also very low accuracy based on ultrasound only. So it's very exciting. And this is also emphasizes the value of the larger imaging, larger benign lesions. So this one based on the X-ray CT, you can see this is a big mass there, and radiologists read as highly suspicious, and because of the size and texture. But then photoacoustic signal, you can see the ultrasound and then the hemoglobin on the left bottom panel and the oxygen saturation, basically not much signal. So this case, it turned out to be a large benign fibroma. It's a kind of like a stroma lesion, but it's kind of big and solid, but really not a cancer and a benign lesion. So we kind of encouraged that there's good the indication that the photoacoustic imaging can be useful for separating malignant versus large benign lesions. And then we engaged in this round, we engaged our 3 radiologists, and then they all read the lesions based on ultrasound and the CT. They grade the lesions based on the current state of the art. They call the ORAS. Some of you are familiar with the breast called the BIRAS. Here's the ovaries called the ORAS. This is recent 2 years. Radiologists want to standardize the reading. So this table you see is based on the ultrasound, and CT image is in their knowledge too. And then you see that most of these cancers, for the second column, you see those are the cancers. And then you see the cancers, their reading are higher from 10 to 50% ORAS 4 category to ORAS 5 category. So they're reasonably accurate in terms of identify the cancers when they're large, and the size is kind of reasonably read from the transvaginal ultrasound. But if you look over the fallopian tubes, this third column is the fallopian tubes. Fallopian tubes is a cancer. The size is small. If you see their readings spread out from 4, 3, 2 are very low suspicion to 1, even no normal. And they're not very good in detecting when the lesions are small. But fallopian tube cancers is believed to be the origin of higher grade serous carcinoma, which is a very lethal type of ovarian cancer. We found more 40–50% in the ovarian cancers. So this is one example I showed you that is encouraging that photoacoustic signal. Later you'll see statistic, it can be able to detect those while radiologists are not certain. And then if you look over this yellow numbers, this is a category of large benign lesions. You see reading by radiology, they're very good. And 2 of them has 30 years experience, and they're very, like Dr. Middleton is writing books and really good. But because of this overlapping feature between malignant and benign, it's very difficult. They put those large benign lesions into a higher risk, higher malignant category. And the other category is this serious and also mucinous, but they're benign cysts with some solid component. You see, this is a difficult area. Radiologists really need the help to identify better of cancer versus benign. So this will help the surgeons to manage surgery better. So we will see, this is purely based on the ultrasound and with knowledge of the CT. And we can see how we do with photoacoustic imaging. So we had all these features, we rank them based on the performance, because we can characterize the photoacoustic by calculating the hemoglobin concentration. And we also can calculate the oxygen saturation. So we rank them. We find that the total hemoglobin is the most important feature to identify cancer versus benign. Second most is this CA-125, and the elevated in a certain portion of ovarian cancer patients. And then also radiologists reading, because their reading integrated a lot of things, and X-ray CT size and the menopausal status, and also color Doppler score. This is also very important. SO2 is the number 4 important parameter. So this is our current reading. And size is important, but it's not as important as already integrated with radiology ORAS reading. And this is what we do with ROC analysis. So if we do CA-125 only, we're reaching ROC of 0.79. You know that 1 is the best, right? So the ORAS itself is getting to 0.86, which is this black curve. And then the photoacoustic signal based on the hemoglobin and the SO2, we find that we can achieve AUC of 0.9. And when we combine these 4 important parameters together, we're reaching AUC of 0.97. So this is just our recent data we finished, and we're continuing recruiting more patients to validate the data. And we see a hope that the photoacoustic imaging might be able to use for early detection, may also be able to do better in terms of separating large benign lesions from malignant lesions. But again, photoacoustic imaging is integrated with commercial ultrasound for the with the ORAS assessment, but we're improving the ORAS assessment plus the blood marker. So I'm really thankful for this group of divan surgeons and radiologists who actually help us to move forward on this project. And next, I will switch gears to talk about using co-registered ultrasound and the photoacoustic imaging for the colorectal cancer study. So in the colorectal cancer study, we targeted for rectal cancer treatment response assessment. So I will tell you why is that. Because the colonoscopy actually is very good in terms of detecting colon cancers and also rectal cancers. But treatment response monitoring for rectal cancers is nothing is there yet. So this is the current clinical problem. And this is a problem actually when we talk to surgeons, and they keep emphasizing the importance of the problems when I started as Washi about 4 years ago. So for rectal cancers, you know that the rectal cancer happened here. And then colon cancers is descending, transverse ascending, and then to happen during the in the colon region. And then if for the rectal cancer, typically they will treat the patient with radiation and chemotherapy for 6 months. After treatment, in the older practice back to 2 or 3 years ago, they cut a lot with the surgeons cut most of them out because they don't know whether the after treatment is residual tumors there or patient responded. And this is certainly not good for patient quality of life. But the problem is that after treatment, the scar tissue is very difficult to separate from the residual tumors. It's very confounding issues to detect better for those patients who responded compared with this patient who have residual disease. So they cut a lot, which is not good for the rectal area because soon after the rectal tissue getting cut out, and patient will have tubes to support their regular life, and then basically the tubes will help with their the pool, and it's not a good quality of life. Then they will suffer that for the entire life. But if the colon cancer is a little different, they can cut a piece out and then stitch to the other side, and then the colon can still function. So this is a current problem. So this is called the new kind of like wave in the general surgery in the colorectal divisions that they call this a watch and wait. This has been a while for a couple of years. And this watch and wait will do what? They will basically say, okay, we don't know for sure there's a residual tumor or not. We felt like probably fine. And then they just watch the patient 6 months, 3 months actually initially, 6 months, and then 2 years to see if there are any recurrence of tumor. But this is certainly very risky, right? Because the patient recurrence rate is quite high. It's 1/3 of the patient to half of the patient may have a recurrence. And then this is not very safe compared with you immediately cut it out if a patient definitely had a residual tumor. But then this watch and wait is not a practice in a lot of community hospitals because the imaging facility and also the surgeon's confidence on this watch and wait is not as higher as in this higher level of research hospitals. So this problem sparked really a lot of interest to monitor the response and then also predict the response at the end of the treatment, radiation chemotherapy around 6 months, and to predict to who has a residual tumor. And then for those, you cut it out. And for those who have a good response, no residual tumor is there, and then do not cut it out. So this is a really kind of like do better than standard of care that on this group of patient. And standard of care right now is not very good, as I mentioned. The X-ray is not very the X-ray is not used. So the scope is not very good because you only can see surface. So you cannot see what's underneath the residual tumor or not. MRI is not very sensitive because there's a lot of scar tissue. So this is the current problem. And then I would just, before I talk about our approach, and I want to give you a little anatomy about the colon and the rectal tissue. So for colon and colorectal tissue, and it's very nicely structured with this mucosa and the submucosa layer, and then underneath is the muscle layer and the serosa. And in terms of blood vessels, you can see that for normal colorectal tissue, and underneath the mucosa and the submucosa is very well structured the vasculature support for the mucosa and the submucosa tissue. So this is giving us some kind of sense that there's a normal pattern we can use to separate the normal from the cancer. And once the cancer grows, and then it will start from the mucosa, and most often start from mucosa, and then penetrate deeper to the deeper layers. So this is like a cancer development. So with this knowledge, we started with the photoacoustic the microscopy, because we want to examine the surface better with a resolution which is higher. And the same principle, light illuminate, and then the illumination. Let me just go back again. Yeah. So light will illuminate, and then the illumination will generate a photoacoustic signal, and photoacoustic signal can be detected by transducer, ultrasound transducer. And when we scan, we can get the B scans. And this is very similar for people working in OCT area, and then this is the same like the B scan. And then so we developed the first, we don't really know, right? This is the first time we do this, and then no data available on the vasculature pattern of normal rectal tissue versus the cancer. So we developed the probe, and then we like to see from ex vivo sample first. So this is the one you see in the middle column. This is the ultrasound. You see very clear, this is normal. Very clear layered structure. And then when we add the photoacoustic, the co-rigid photoacoustic, we see a very nice structured, kind of we call layer-like of structure because of the vasculature distribution in the mucosa and submucosa. And then when we have this polyps, you can see on the right side, and then this normal the structure is getting distorted, and this is a photoacoustic signal. So this is a polyps, and polyps is a precancer. And this is another, again, this is a like a normal in the middle, and this is a cancer case. And you see there's a very messy from ultrasound, but ultrasound is not very good to detect viable tumor versus the normal, because it's just after treatment, ultrasound, they just become images become very muddy, hard to tell tissue is normal or scar or cancer. But we see photoacoustic signals kind of distorted, and then you see the rupture of normal vasculature layer. And this is another example, and this is in the middle is the cancer case, and the top ultrasound, and the middle is the photoacoustic. You can see the distorted vasculature pattern. And then it's interesting if you see the right column, and the ultrasound show this patient had no residual tumor, but they still cut it out because of the current problem of identify better of no residual tumor. And then if you see there's a normal ultrasound showed very normal, and photoacoustic showed that the recover of the vasculature pattern, because this is a responder, no residual tumor left. So this is very encouraging. It shows that if we use normal as a sort of a reference based on the normal ultrasound and normal photoacoustic layered structure information, either morphology, ultrasound, or vasculature photoacoustic, we might be able to do better compared with ultrasound only, and also do better than MRI. So we developed the in vivo probe, and the probe basically was a modified version of this rigid probe because we're targeting rectal tissue area, and the probe is able to spin 360 degrees. And then the probe is filled with a balloon, covered with a balloon and filled with water, and inflate, and then photoacoustic and ultrasound sensor simultaneously rotate. And photoacoustic sensor is similar as the most of the group are working on with the center hole, and the light can deliver through the hole, and the ultrasound transducer detect from the ring transducer. So this is what we see. And this case is if you see, this is an MRI. MRI in this case showed that there's a residual tumor. And ultrasound, you see this box region shows some kind of structure there, but it's not very clear. And this is a photoacoustic show the very disrupted vasculature signal, not as regular as the bottom, which is normal region. And now I'm introducing this deep learning. So soon we see this pattern, we see many ex vivo cases, and we started kind of thinking, how can we quantify this, right? And we can certainly see by eye, and but we were going to, when we the probe pull back, ultrasound and the photoacoustic all together will be several hundred images, because our laser is 1 kilohertz range, and the slowly pull back will be several hundred images. How do we quantify? How do we give surgeons some kind of tool to kind of quantify based on the vasculature information, whether it's likelihood of a residual tumor or likelihood of normal? So we borrowed this deep learning CNN neural net and developed our own neural net, and then trained the neural net with a larger number, reasonable number, I won't say large, or several hundred the B-scan with a region of interest cropped, and we trained the neural net to represent normal. What is different than normal will likely predict the abnormality and residual tumor. So this is our thinking, and it turned out that after training and the initial evaluation, the deep learning works, and this is our training set with several thousands of region of interest cropped from ultrasound, and also cropped from the photoacoustic imaging, and from the ex vivo patients, and also 5 in vivo patients for training. And this is what we see. This is a testing. This is what we see. So I walk you through this little busy picture, and then you see MRI in this case indicated that there was a post-treatment fibrosis, and the diffuse MRI actually is also used in regular standard of care evaluation, but shows no tumor. And then this is the scope image. The surgeons use their camera, and there's something scar tissue, and they don't know what this is. And then we use the photoacoustic in the middle. You see this is ultrasound, and then the number here corresponds to the probability of output. If the higher number indicates cancer, if the lower number indicates higher number normal, sorry. Yeah, lower number indicate abnormal or cancer. So photoacoustic correctly predicted that in this case there was a residual tumor there. And then this one turned out to be residual tumor with many foci of tumor. And this is a normal region. We use normal as the comparison. So normal region showed a very high probability of normal. So this is a good, successful story for the photoacoustic imaging and combined with neural net, and we can actually predict the response. So with the time, I'll just basically go, oh yeah, so this is a 5 testing cases, but this is all normal regions. So you can see that the first column is the ultrasound that showed a nice layer structure. And then this, the right one is the photoacoustic. You see the very nice vasculature pattern. Those are the normal region. And then in the cancer region, it's very heterogeneous. And then you see this one here, this is a photoacoustic, show the disruption of the normal vasculature distribution. And this one has a cancer, residual cancer. And this one, you see this region show the second one show the residual tumor here in the photoacoustic imaging. And third one also show the residual tumor here. And then the fourth one is on the top region, there's a big residual tumor. And then the last one is very interesting. You see that the photoacoustic signal is reasonably distributed, the red is reasonably uniformly distributed. This patient had a complete response. We predicted reasonably well. So I will just show you a movie to see that right now we actually work with the surgeons in trying to automate everything and then give the surgeons a confidence in the tumor bed region. If you see the green box, that will correspond to residual tumor, lower probability. And then the blue box corresponds, let me just play it one more time. And then the blue box corresponds to the normal region. So this is giving a surgeon a real-time tool to characterize, quantify the residual tumor versus a normal tissue. And this is another example. This is a complete responder. And you can see that everywhere is a higher probability. The green box corresponds to the tumor bed area, but also show the higher probability. So this patient didn't have a residual tumor left. Okay, so with that, I think I'll just summarize quickly. We have also this ROC based on the testing patient region we interest. We achieved quite a higher detection based on the photoacoustic signal, we achieved AOC of 0.98. Okay, so basically, if I quickly summarize, and that will be that we are very excited that this new tool, photoacoustic combined with ultrasound and neural net, will be able to provide a real-time assessment tool for surgeons. And certainly we have more work to do to validate the data and fine-tune the neural net, and also trying to get NIH funding to support the larger scale of this work. And the last topic I'll talk about, this topic is very quick. So I will talk about breast cancer. And the breast cancer, we're actually using the diffuse optical tomography technique. And this technology, some of you work with Dr. Bruce Trenberg before, and you work in this area. So the goal is trying to use this technology to reduce benign biopsies. And let me just get you some facts. So we know that more than 1 million women per year in US will get this biopsy. And the large patient of population of patients, 85% of the patients are having the benign biopsies. And certainly the cost and the patient anxiety is an issue. So our goal is to use the diffuse light to reduce benign biopsies. However, we cannot compromise the cancer detection, because if we miss cancer and we reduce benign biopsy, but we miss cancer, is not good. And we need to guarantee that we don't compromise the cancer detection. So this the diffuse light combined with ultrasound. I have been working on this for a number of years. Initially, we thought that we were going to detect more cancers, but then later, because of the resolution of the diffuse light is lower, and also the X-ray mammogram combined with ultrasound, the radiologists are reasonably accurate in detecting cancers, and they do not need another modality. I would say conservatively, they probably do not need another modality unless that modality is very super active to pick up more cancers. But actually, they are very accurate. You will see the data. They are very accurate in detect cancer, but they are not good in terms of a large number of benign lesions. They just send them for biopsy. So this is our problem, the problem we're trying to improve and solve. And diffuse light, you know that the footprint is large. So our probe is big, for like 10 centimeter in diameter, and the light probe, probe and light were delivered to the probe, and then it reflected light will be picked up by the detectors. And again, the contrast is the tumor angiogenesis. So how do we do that? We actually had this probe, and then the radiology use ultrasound, and then we put the ultrasound in the middle and then lock the probe, and then we can very easily to handheld and then scan the lesion area for better diagnosis. So we need ultrasound. We're not using the diffuse light for detection, but we're using diffuse light for improving the characterization and accurate diagnosis. So the new study design, we started about like 3 years ago. The reason I say new, because this is a little different than typical. We use diffuse light itself with ultrasound. We combine with radiologist reading. So radiology basically will read the ultrasound and mammogram first to give a BI-RAS. BI-RAS 4 and 5 are 5 is definitely cancer. 4 is highly 4 is suspicious, and then 3 follow up, 2 nothing, 1 nothing. But then after they read the optical image, the ultrasound imaging, and then we give them DOT data, and then we certainly train them, and then they will see whether DOT presented to them will increase the confidence of cancer or decrease the confidence. Say, okay, no biopsy. So this is a study design. We want to see how many we can reduce in terms of normal biopsies. And this is a very, this is an example that this is a tumor, and this is a DOT image. DOT is basically each score you can see slide correspond to 0.5 centimeter spatial image. Ultrasound is a B scan, and then the DOT one slide, another 1 centimeter, 1.5, and 2 centimeter. We use ultrasound depth to localize the reconstruction. And in this case, all readers, 3 radiology readers, upgraded the BI-RAS 4C based on the conventional imaging, CI, to BI-RAS 5 is definitely cancer. And they're increasing their confidence. And in this case, and we really do not see very much. You see very little DOT signal, and in this case was benign. Later biopsy find out was benign, and then radiology actually 3 of the 4 radiology downgraded the reading from 4A, which is a biopsy, to 2, or 3, which is follow up, basically no biopsy. 1 reader didn't change their score. So this is like everything done after the before the biopsy result is given. So radiology read them without biopsy result, and our DOT, the engineers gave the radiologists the DOT data without knowing biopsy result within 24 hours or 1 day. And then after that, we accumulated the score. We want to see how this correlate with the final reading. So this is very interesting. So I'll explain this little table. So if you look around the left side, and this, you were familiar with this table, the top is the mark is the biopsy result, the malignant and the benign. And this is the reading for biopsy, whether they want to biopsy or not. And then we use biopsy as a kind of a positive in this table, the evaluation. And now this is a benign category. You see the large number of benigns all getting biopsied here based on conventional imaging. And this portion is like a follow-up. And because everyone read it differently, we have 4 radiologists involved, everyone read it differently. And there's even the biopsy, there's certain number of patients, they don't feel like they need to biopsy at the very beginning. But then now if you look over this table on your right, you see that the benign category reduced a lot. And then there's a large percentage, 20% of benign biopsies downgraded to follow-up because of the DOT data presented to them. They reevaluate their decision. And we didn't miss one, I mean, their downgrade from cancer to follow-up. So this is a 146 patients that we collected over and up to last year summer. And recently we finished about 200 patients. And then so far we haven't, the recent patient, we haven't get all the radiology together to read one more time. But from 148 patients, we see that we actually can reduce benign biopsies by 20%. And this is a lot compared with 1 million biopsies per year, and 85% of the patients all get this benign biopsies. So this shows that promising data that we might be able to use the diffuse light with the radiologists and then improve their accuracy in terms of reading, particularly reduce benign biopsy. But we certainly have to be cautious that we don't compromise the cancer detection. So this is like a summary. So we see that adjunctive ultrasound guided DOT can lead to more than 20% reduction in biopsy and less than 1% downgrade of cancer to non-biopsy follow-up. And right now we're automated the processing. Not only we know people working DOT, you know that we also have like post processing as the filter the data and also the processing data. So we're trying to use neural network to streamline the data processing, and this way we can immediately provide the radiologists rather than one day, and with the DOT result. Hopefully, this can be integrated with the reading and serve as the goal we're trying to achieve to reduce more normal biopsies. Okay, with that, and I certainly like to thank our group for like the people who work hard on instrument, algorithms, and data processing, and thank for the NIH funding. So with that, I like to answer any questions from the audience, and thank you very much. Hello. Oops.
Okay. Thank you, Quing. And
Yeah.
I think Quing will be happy to answer question. So you can.
I can quit the right.
Mhm.
Oops, stop sharing. Right. Okay. Thank you very much. Yeah.
Maybe I can start with the first question.
Sure.
For your ovarian cancer detection with intravaginal access, is there like blind spots that ultrasound will not be able to see, or you essentially can screen most of the ovarian structure?
It's a good question. We basically screen more than 95% of the patients, and most often those lesions are between 1 to 5 centimeters in depth. Very occasionally, some ovaries be really deep in the more than 5 centimeters in depth. And in this case, we will have to miss, but most patients we can get them.
How long does it take to screen typically a single patient?
You mean imaging time?
Uh-huh.
Oh yeah, photoacoustic is real time, basically, because
Okay.
we have a full wavelength. There's a little toning time, about a few seconds of toning for wavelengths, and then we can immediately provide the images for the full wavelengths combined to provide the hemoglobin and the oxygen saturation. Yeah.
Okay. Other question from audience?
I have a question. Firstly, thank you so much for the wonderful talk. It's really exciting to see this photoacoustic and ultrasound has been really moved to the clinic, and you work with a lot of clinicians. That is great. So you mentioned that the dual model system with photoacoustic and ultrasound was working with some company to build the prototype, right? Most of the ultrasound system, you acquire the data and save it in a computer waiting for post-processing. So how do you do the real-time signal processing, data acquisition, and everything, imaging reconstruction?
And this Korean company, actually we didn't work with them, but they sell this research system. It was their standard clinical system. Also the company name Apogee, and they sell the research systems. And then just recent years, I think we have some trouble in American market, and they provide basically a real-time display, but it was a single wavelength.
Okay.
And so soon we get the probe in, and then when we acquire ultrasound and photoacoustic, all coverages all together. This is single wavelength. So we developed this our own code, basically just combine full wavelength data to generate hemoglobin and SO2 saturation, and it was all in the reasonable time frame in the second, soon after the motor moving, finish the full wavelength, because mechanically toned, the laser is mechanically toned. It's just few seconds, and then we will be able to process the data and then display the hemoglobin and SO2. Yeah.
I see. I saw you. I read some of your paper on FPGA and those data processing software or interference between the hardware and the software. Are you doing more research on that, or?
Actually, that was back to the photoacoustic imaging. We had a little many years of development. We started this on 2018, and we did develop this FPGA base. We even have our own real-time ultrasound system, and the FPGA was combined with our own ultrasound system, so also real-time. But the problem is that as soon as we start a patient, radiologists do not like our imaging quality at all. And they say, oh, this is a crap. And we don't read the ultrasound of your system. Even we tried our best, but our quality is compared, probably even better than ultrasonic. I hope there's nobody in the ultrasonic people there. Better quality than that, but still the radiologist is so used to high resolution GE system. So we stopped that, and that's why we purchased this research unit. And this company actually, Apogee, and their clinical system is sold in US market. And then the research is just the addition of including the photoacoustic module. And the imaging quality is decent, and still not as good as the GE system, but it's decent.
I see.
So we didn't, to answer your question, we didn't continue that FPGA. We still have that system, yeah.
I see. I want to follow up with, since you work with so many surgeon and radiologist. These people in clinic is sometimes work very differently than we as an engineer. So what would be the challenges and opportunities to work with them? And can you share with some of your experiences on that?
Yeah, this is a good question. I think the key is that you have some data excite them, and also they feel like they can contribute. And then, for example, in our ovarian study, they're involved with ORAS, and then the next stage we want to get them involved on reading photoacoustic scores of photoacoustic as well. So they're very excited. And then for the breast study, we already kind of get them engaged because we trained them with our existing DOT data, breast data, and then they kind of get familiar. And then some of them even asking, how am I doing? How am I doing? Because we put a table out, right? And they don't have the biopsy result when they grade the ultrasound and the DOT. They want to see how well they do. So I think anything like when they see they can contribute, and then you can solve the problem, or even not solving the problem yet, but look interesting and promising, they like to get engaged. And so this is what I see that was very interested for the rectal tissue. And then they always, because for example, they put the patient in the surgery, they really don't know this patient in some cases. Some cases they don't know there's a residual tumor because they see by scope, they see something there. But then if it's in some cases they don't know, they say, oh, this is a case I really need help. Can you tell me something? Then we said, okay, we're not comfortable yet because we're still very little patient. So far, we only got a little over 10 patients. But you can see that they really need something. So I think that's the way we engage them. Yeah.
Wonderful. Thank you. Thank you so much.
So just keep talking to them. They will be very excited. And even like in a very initial stage, for example, when we started the colorectal study, we didn't have data from patients yet. We just keep engaging them. Yeah. But also another good source is that engage the younger residents and fellows. They're interested to do something.
Right.
And then they bring the technology to their attending physician's attention. Oh, here's something good that we should try. And it was another channel I see. It was very good to engage them. Yeah.
Okay, thank you.
Okay. Any other questions from?
Yes. Thank you, Dr. Zhu, for a wonderful talk. Actually,
Thank
I was
you.
wondering, regarding the breast cancer, what was the notion behind choosing diffuse optical tomography in combination with ultrasound instead of using photoacoustics or multispectral photoacoustic tomography for it?
Yes, a good question. Actually, I started this about probably already 20 years. And at that time, we started the DOT because of DOT was in a kind of rising time. And then also DOT is more lower resolution, but it's highly sensitive because there's no light to sound conversion as a photoacoustic imaging. So we are kind of okay, and why do we use ultrasound guidance? Because the diffuse light is very difficult in terms of localizing the region of interest. We use ultrasound to localize and to shine the light, and then we use reconstruction algorithm to localize the reconstruction so we can do better. And photoacoustic breast imaging actually was a little behind the DOT. And but recently, the Sono medical instrument, they actually build the system, commercial system, and they get FDA approval actually, and then they work on the breast imaging, but it's different resolution. If you look over their publication, they're seeing some vessels fitting the tumor, but they really do not see the bigger tumor mass. And the DOT low resolution, but highly sensitive because of the no light to sound conversion. Actually, we see a big mass, and then that's for diagnosis is very good to increase their like radiologist confidence or not. I would say both have a very promising role in terms of reducing benign biopsies.
Okay. Okay. Thank you so much.
Thank you.
Any question? Okay, if no question, let's thank the speaker again.
Thank you.
Okay, I think the LAMP seminar is over, and but Sean and Dr. Zhu, please stay there. Stay
Yeah.
here. Thank you, Aaron and Richard, for coordinating.
Thank you, Junping. I will talk to you
Welcome.
later. And thank you, Aaron. Thank you, Richard. Yeah.
You want to stop recording, right, Richard?
Yeah.